to police a little bit some of the video feeds. You know, Zoom bombers, they're real things. So just let us know. We'll eject them, throw them out, so that we can all have a nice conversation tonight. And that's what it is a nice conversation.
Mm-hmm.
Yeah, you try to, like, stay on. Even if we see that, we'll try to kick him out, but don't panic and just, stick around. It will be a great session. I'm very excited about it. Again, I still have a lot of people joining in at the last minute, so we will start in 1-2 minutes. It's just almost there.
Nice.
So we have about 120 people registered. So they're more like trickling in. Right now we have about 41 people.
We definitely don't want people missing Dr. Miller's talk. Jared's got us all lined up. He's gonna hit us off first base probably, or get us even to third. So.
Mm-hmm. Yeah, will they mute us when the speakers start speaking? Or
yes, I will. Me and Viet will mute everyone when the speakers start. And if anyone has any questions, either chat or you can raise your hands. And if someone wants to come on the camera, just write in the chat box or raise your hand. We will let you, share your camera as well. All right. So I as soon as we hit 50, we will start. We are at 44 right now, so it won't be long.
And I will apologize up front if there's any slight pause as I kind of maneuver through different parts of hosting here. I have 3 monitors up, so if you see my head move either way, you know what I'm doing.
All right, we are at 46 now. As soon as we hit 50, we'll get going. So we'll keep doing these webinars for the next couple of months. As you know, a lot of physical conferences have canceled because of COVID-19. So this is the way to stay in touch with our audience, and you can follow either Viet or me on Twitter, where we can let you guys know about our upcoming webinars. We did one great webinar last month, which was on updates in heart failure and updates cardiac imaging and COVID-19 and cardiovascular complication. And we have that on our YouTube channel. You can still get CME even if you go back and watch that. Next month, I'm planning to do a dedicated heart failure updates. And we will have faculty from Columbia University, New York, Texas Tech. And of course, Dr. Martha will be, there. Dr. Gulati will be there as well. So, and then the month after, we'll do one on peripheral vascular disease and venous disease. We'll keep doing that every month for the next few months till we start these physical conferences again. So 7-4 will start at 7-5.
And just to reiterate to everyone, I mean, this is our way of making sure we help level up our partners in the community and globally. It sounds like now that we've got a lot of attendees from across the world. So we just want to have a good conversation, bring in experts like Ed Miner, Rehan, and Jared Miller, and of course having hosts like Dr. Gulati. We really hope to bring our discussion and our care upwards.
So I'm getting a lot of messages that there's some technical issue for a lot of people. Passwords are not working, but that's okay. We can bring him in as we go. I think we should go ahead and start. I'm going to open my slides. Can you guys see it?
Yes.
So we welcome you all from Salt Lake City, Utah. Good morning for people who are joining in from Australia and India and Pakistan, and we have some people, or good evening for those who are in the US. So this is our faculty here. Trying to get to the next slide. All right, so I have to do this. This is the CME provided to us by Steward Healthcare of Utah, which is accredited by the Utah Medical Association. And you can claim your CME at this website or using this barcode. Again, we will be recording this this webinar, and you can easily access that later on. I'm trying to get to the next. Can you guys see my slides?
Yes.
Yes.
All right. So first of all, let me welcome Dr. Gulati. She will be our co-host and moderator at this educational webinar. She is the Division Chief of Cardiology for University of Arizona College of Medicine, and she's also member of numerous advisory boards and societies, including the American Heart Association, as well as American College of Cardiology. And Dr. Gulati is very passionate about the study of women and heart disease, as well as about its prevention. So this is a great honor for us that she is joining us today. I'm trying to get on the next slide. So so why AFib? Why we are doing this AFib talk today? Because AFib is the most common type of cardiac arrhythmia, and up to about 6 million people in the US are suffering from AFib. And AFib accounts for about 500,000 hospitalization every year in the US, and it also contributes to about 158,000 deaths each year. When the standard stroke risk factors were accounted for AFib, the AFib was associated with 4 to 5-fold increased risk of ischemic stroke. And stroke caused by AFib are usually not the small ones, they're usually the severe ones. So that's why this talk is so important. And there's not a week that doesn't go by that I get calls from my primary care physician referral question about anticoagulation, the risk of bleeding versus stroke, whether these patients should get Watchman devices or not. Just kind of give you a brief overview about because a lot of people would be mentioning in the lecture about, the AHA or ACC grade of recommendation, whether it's grade 1, 2A, 2B, 2C. So grade 1, which is, you see the green one, is a strongly indicated treatment or medication, which is based on randomized controlled trials. That means you should absolutely do the procedure or give that medication. The one in red is class 3, which is intervention is not useful, effective, or maybe harmful. That means absolutely not indicated. The one in orange is class 2B, which is almost class 3. That means usefulness or efficacy of this treatment is less well established by evidence or opinion. So if you look at the Watchman devices, and the one thing that concerns me is that in Utah, one of the for-profit hospital corporation ran these newspaper ads. They were all over the newspaper, and the next day the patients were coming to us that they should get Watchman devices. But if you look at the guidelines, it's class 2B. Class 2B is a very weak recommendations. Again, there's not a lot of trials and evidence, and it's usually indicated in patients who are at increased risk of stroke, who have contraindication to long-term anticoagulation. Remember, contraindication to long-term anticoagulation. But then again, there's still people trickling in. So Viet, can you help enter those people there?
Yeah, sure. So Hal, there may be a some type of window open near your other one. Occasionally, I think the audience is seeing up at the top of the screen, it says something, please move a window away from the shared screen. And I'm not sure if you happen to have a...
No, I don't have anything open. That's the
Okay.
slides. So basically, if I go to Watchman website, this is what is Watchman is covered for patients who need alternative to oral anticoagulation, including those who have an active lifestyle, a physical occupation, a trouble maintaining a stable INR, or problem with treatment compliance. So the ACC recommendation is to be, for those patients who have contraindication of anticoagulation. But I've seen patients like coming asking me that they are like skiers and, should they get Watchman devices or not? So those are the questions. Being an interventional cardiologist, that's why I'm here. Even I don't have real answers for this, and I would rather refer those questions to my electrophysiology colleague. So let me stop sharing my slides and let me give the podium to Dr. Jared Miller. Dr. Jared Miller is the electrophysiologist at Intermountain Heart Center. And he will be talking about how to assess the risk of bleeding versus stroke in patients with AFib, and also when to refer these AFib patients for AFib ablation. Dr. Miller?
All right, thank you. Thanks for having me. Let me see if I can get my slides to display here. All right. Can someone let me know if they can see my slides there?
We cannot yet, Jared.
Okay, that's not a good sign. Let's see. Nothing still?
No, and sometimes when you hit share screen,
Yeah.
yeah, it should pop up with the one that you want to share.
Okay, let me unshare. So I have host disabled attendee screen sharing.
Oh,
Viet, can you take care of that?
yes, let's see.
While we're waiting, I can give a preview of one question. I'm from Utah, and I can say confidently, skiing is not a reason for a Watchman device. So.
I have seen people getting Watchman devices because they have high, risk of bleeding.
Okay, cross-country skiing is not a reason for a Watchman.
Okay.
So you should be able to share now.
How about
Okay.
try now?
Yeah.
Perfect. There you go.
All right.
And let me go to, here we go. And all right, well, thank you for having me. So the topic I was asked to discuss is assessing stroke risk and bleeding risk. And I said that wouldn't take a full 15 minutes. So I'll also just chat about AF ablation for a moment. So first, assessing stroke risk. Just before I even get to there, I think one thing to point out, this is some old data from back when we were using Coumadin, but at all CHADS VAS scores, cardiologists are more likely than primary care doctors to anticoagulate. So when you refer to a cardiologist, you have a higher chance of your patient coming back with anticoagulation. There's some other data that shows if you send them to an electrophysiologist, they're even more likely to come back on anticoagulation. And if you send them to a dentist, you'll probably stop their anticoagulation. That was a dentist joke. Okay, so Hale mentioned this, but atrial fibrillation obviously is associated with strokes. And he mentioned this, but it's also worth pointing out that they're worse strokes. So there's higher morbidity. I'm getting some feedback from some other. Higher morbidity and mortality strokes with AF-related strokes than non-AF strokes. And that's shown in both of these graphs. And in particular, strokes in women with atrial fibrillation are particularly devastating. So I don't have anything groundbreaking on assessing risk of stroke in patients with atrial fibrillation. I use the CHADS-2 VAS score, which I think every other cardiologist that I interact with, I believe, works with. So just to recap, age, point for 65 to 74, 2 points for age greater than 75. sex, heart failure, hypertension, 2 points if you've ever had a stroke or other embolic phenomenon, vascular disease, which can sometimes be a little confusing, but the biggest ones would be coronary disease and peripheral arterial disease, and diabetes as well. And this is probably an oversimplification, but with a CHA2DS2-VASc score of 1, I think of about a 1% risk of stroke per year, 2, 2% stroke, 3, 3% risk. I think that's just a quick and easy way to think about it. Although as you get to the higher numbers, it goes up a little bit more than the actual CHA2DS2-VASc number. So I think the most important thing to take into account with the CHA2DS2-VASc score is what's not in this score. And so what is not in this score is whether the patient is currently in atrial fibrillation right now. So that is not a factor for me in their decision of whether to anticoagulate. So you'll, again, whether that's paroxysmal or persistent is not a part of the score, and whether they're sitting in front of me in sinus rhythm or atrial fibrillation doesn't impact my decision. What impacts my decision is the CHA2DS2-VASc score. Okay, that's what I have to say about stroke risk. So now let's talk about bleeding risk. And I'm going to give a strong opinion about the HAS-BLED score, and I welcome feedback or discussion. So this is the HAS-BLED score. So age, so many people here have maybe used this score. Maybe they calculated CHA2DS2-VASc score first, and then they calculate a HAS-BLED score to help balance the stroke risk. So age greater than 65, hypertension, stroke, renal disease, liver disease, labile INR, which isn't even remotely relevant because most of our patients are on NOACs, other meds that cause bleeding, that would be mainly aspirin, and medications like Plavix, and then alcohol use. And so if you put that next to a CHA2DS2-VASc score, it starts to look like a pretty similar score. So age is right in common, hypertension is in common, stroke is in common. It's pretty hard to have vascular disease and not be on aspirin. And then it's pretty hard to have renal disease without also, or I should say the other way around. If you have diabetes and or vascular disease, there's a pretty good chance that you have renal disease as well. So as it turns out, the HAS-BLED score is pretty good at predicting who will bleed, but so is the CHA2DS2-VASc score. Actually, the CHA2DS2-VASc score is equally good at predicting who will bleed. And so there's really no need to calculate another score because you've already calculated the CHA2DS2-VASc score. And then you might think, well, maybe there are patients with a low CHA2DS2-VASc score, a score of 0 or 1, who have a really high HAS-BLED score. So maybe I can pick out some people with a low stroke risk and a high bleeding risk. And it turns out that just there aren't many of those patients that exist. And that's because the scores are calculated so similarly. So here are my, I think, accurate statements, but they might be a little controversial. So the CHA2DS2-VASc score is really good at predicting, or is good at predicting who will have a stroke, but it's also good at predicting who will bleed. A HAS-BLED score is good at predicting who will bleed, but it's also good at predicting who will have a stroke. High CHA2DS2-VASc scores predict high HAS-BLED scores, and high HAS-BLED scores predict high CHA2DS2-VASc scores. So I don't find the HAS-BLED score helpful because I think it's redundant with the CHA2DS2-VASc score. And it's sort of common sense. The same type of risk factors, being older and having lots of comorbidities, are going to make it more likely for you to have a stroke. And being older and having lots of comorbidities are going to make it more likely for you to have risk of bleeding. So I really go by the CHA2DS2-VASc score, and I don't compare that to another number. I've seen algorithms that people follow that are totally unproven of, subtracting the HAS-BLED score from the CHA2DS2-VASc score. Things like that are not validated, and they're not even logical. So I use a combination of the CHA2DS2-VASc score and common sense. So for example, in the HAS-BLED score is alcohol use. So I'll incorporate that. I'll incorporate, amazingly not in here is, have you fallen or do you fall often? So I would say I add common sense to the CHA2DS2-VASc score. I think in line with other data, I'm fairly aggressive about anticoagulation because strokes are so devastating. So I'm going to toss in a couple of bonus opinions or things that are, I guess, sort of anticoagulation related pet peeves, I guess, of mine. So this is just a sampling of trials of NOACs versus warfarin. There's nothing special about apixaban. I feel just as good about Xarelto or Pradaxa. But I think a misconception is that when Eliquis or NOAC are too expensive, that Coumadin is just as good. And the data, I think, is pretty conclusive that that's not true. So in this, the biggest study of Eliquis versus warfarin in patients with atrial fibrillation, Eliquis had less bleeding, less stroke, and lower mortality. So when someone says they can't afford a NOAC or can't get it, and you offer them Coumadin, just be aware that the cost savings comes at the expense of bleeding risk, stroke risk, and mortality risk, and gas money going to the clinic and some other things like that. So that's one thought. And then my second thought is which atrial fibrillation patients are ideally suited for aspirin for stroke prevention. And so I don't, okay, I won't be dramatic. The answer is none. So I don't prescribe aspirin for stroke prevention in atrial fibrillation. I think you're taking on a lot of the bleeding risk of a NOAC with little to none of the benefit. So there's no CHADS VAS score 0, 1, 2, 8, whatever, at which I'll prescribe or recommend aspirin. I think it gives people and providers a false sense of security that their patient is protected from a stroke, and it's putting them at basically as much bleeding risk. So to summarize, strokes are bad, AF-related strokes are worse. Anticoagulation is good, has bled as it has been. I don't use it. AFib ablation, when to refer, when not to refer. So I call this, I know there's a debate. I want to do an earlier, a pre-debate. And this is another bonus opinion. So is rate control as good as rhythm control? I'll do all the sides of the argument. No, okay, it's not. So I think this whole idea that rate control is just as good as rhythm control comes from this 2002 study. I won't say where I was in my education in 2002. I wasn't an electrophysiologist yet. So this is the study that's most often pointed to for why rate control is as good as rhythm control. So this is a completely outdated study in which AFib ablation doesn't really exist. The NOACs don't exist. Warfarin is used. We didn't have the same understanding of stroke risk and atrial fibrillation. And so in this study, there was no benefit of rhythm control over rate control and some trends towards rate control being better. The reason, I think the biggest reason for this is there was a misconception that if you were maintaining sinus rhythm, you weren't at as high risk of a stroke. And so Coumadin use was a lot less prevalent in the rhythm control arm than the rate control arm. And I think knowing what we know now, even when you're maintaining rhythm control, you still need to anticoagulate. So for many reasons, I think this is an outdated study. And the main reason that rate control, in my mind, is inferior to rhythm control is that people feel better in sinus rhythm, and that rhythm control helps people achieve that. So let's talk about atrial fibrillation ablation. So before kind of when we do it, why to do it, when to refer, let's talk about what the procedure actually is. So there's a concept in atrial fibrillation that the source or trigger of atrial fibrillation is electrical activity in the pulmonary veins that drain oxygenated blood from the lungs back to the heart. And that if you can electrically isolate the pulmonary veins, meaning that if you can prevent those signals from getting into the left atrium and therefore into the right atrium, that you can decrease the amount of atrial fibrillation. So there were some very early observations that atrial fibrillation started with these sort of early PACs, if you want to call them that, from the pulmonary veins. So this is a CT scan rendering of the left atrium. So you're standing behind the left atrium here in the esophagus looking at it. These are the left superior and inferior, right superior and inferior pulmonary veins. Here's the left atrial appendage. Here's the aorta. And so this is an electroanatomic map that I made in one of these procedures. And basically with radiofrequency energy or cauterize around these pulmonary veins and make sure that signals can't get from the veins into the heart and vice versa. And so we draw basically two big circles around the right and left pulmonary veins, and that's the procedure. So just another way of showing this, another map. Here in purple is basically healthy atrial tissue where there's electrical activity throughout it. And then after we've made our ablation, the middle remains healthy, but these pulmonary veins are now electrically silent. And just a reminder that this can be done in one of two ways. I won't go into when we choose which, but you can use radiofrequency energy, or you can use basically freezing with the cryo balloon. Okay, so I think with regards to AFib ablation, just like with Watchman, I think you have to be very honest about what the procedure can do and what it can't do. So what an AF ablation, I would say the data strongly supports that it does, is it helps people maintain sinus rhythm, and that it improves quality of life and symptoms. I think there's plenty of studies to back that up. But I think it's even more important to be honest about what an AFib ablation doesn't do. So there are not, I'm leaving out a study in heart failure, but for the most part, AFib ablation does not decrease mortality and doesn't really decrease strokes. And I think this is the most important thing for patients that I would say they frequently don't know when they're referred to me, don't remember before the procedure, and don't remember at their follow-up procedure, but that's that the AFib ablation is not a pathway to stopping anticoagulation. So if the goal is to stop anticoagulation and they're asymptomatic with regards to their atrial fibrillation, that's not a good reason for an ablation. And the reason for that, I think, if I can go back, is I think a lot of people, I think stroke risk and atrial fibrillation gets oversimplified to stasis in the left atrial appendage. But really, I think the AFib itself is just a marker of a diseased atrium, and that's what puts people at risk of a stroke. And that's why people have strokes in sinus rhythm as well as in atrial fibrillation. And in an AFib ablation, we're basically taking a diseased left atrium and we're making it more diseased. We're adding more scar to it. And there is not data, there's, I would say, some weak data, but for the most part, there's not data to show that if you have a successful AFib ablation, you can safely stop someone's anticoagulation. In my patients, at least, I strongly encourage them to continue anticoagulation even after a successful ablation. One, because I don't really know that I've decreased their stroke risk, and two, because I know their atrial fibrillation will come back. Their atrial fibrillation might come back. All right. Before even referring for AFib management, I think it's important to know obesity is associated with atrial fibrillation, and weight loss improves response to AFib ablation. And so even, this has actually been exhaustively studied. There's a group in Australia that's done tons of research on this. And they show that even if you remain obese, but you can lose 5 to 10% of your body weight, that you can improve your response to an ablation or other AFib therapies. Poor exercise capacity or cardiorespiratory fitness is also associated with atrial fibrillation. And their same group has studied how exercise improves response to AFib ablation. As an aside, you may have heard that lots of exercise is bad for AFib. So there are some studies from a long time ago, 20, 30 years ago, showing that basically marathon runners and ultra long distance athletes have more AFib. And that's true, but like everything in life, too much is bad and too little is bad. So your friend who runs 2 marathons a month probably is at higher risk of atrial fibrillation, but moderate exercise is beneficial. And then lastly, sleep apnea is a huge risk factor for atrial fibrillation. And it's worth knowing that once someone is on CPAP, the response to cardioversion or AFib ablation goes back to the number that would be if they didn't have sleep apnea in the first place. All right, so whom to refer for an AFib ablation? So this is straight out of the guidelines. So basically, you get a higher recommendation if you've tried an antiarrhythmic drug before. But it's worth noting that it is still in the guidelines that you can do an atrial fibrillation without having tried an antiarrhythmic drug. So that wasn't in the previous iteration of the guidelines, but I think a lot of people still think that you have to try an antiarrhythmic drug first, but that's, the guidelines don't say that. And so for the most part, my patients are on an antiarrhythmic drug or 2 first, but if a patient is strongly opposed to medical therapy and interested in ablation, it can be reasonable to proceed to ablation first. And then you get a higher recommendation if it's paroxysmal, meaning you go in and out of AFib on your own, versus if it's persistent, where you're basically stay in atrial fibrillation for more than 7 days or until you perform a cardioversion. And the reason for that is that the procedure is more successful in paroxysmal atrial fibrillation than in persistent atrial fibrillation. All right. So who not to refer for AFib ablation? So keeping in context that AFib ablation improves symptoms, but doesn't decrease stroke risk, doesn't decrease mortality, and doesn't provide an avenue to coming off of anticoagulation. So if they're asymptomatic, then they're not a good candidate for an AFib ablation because it's hard to improve the symptoms of someone who isn't symptomatic. So a good way to test that in clinic is to ask people after you get their EKG to guess what rhythm they're in. And if they're in AFib when they think they're in sinus or vice versa, that's a good sign. Or that's a sign that they're not symptomatic. There's kind of a newer phenomenon of what's called subclinical atrial fibrillation. I would consider that a variant of asymptomatic. That's incidentally discovered atrial fibrillation on a pacemaker with an atrial lead, an ICD, or a heart monitor. Sometimes these are 4-second episodes or 1-minute episodes, but the patient's unaware of them. Again, the point of this is to improve symptoms, so subclinical AF would not be a good indication for an ablation. If someone has been in atrial fibrillation for years and years, or the answer is usually more vague, for as long as I can remember, or I have no idea, they're not a good candidate for 2 reasons. One is if they've been in atrial fibrillation for years without saying anything about it, they're probably not particularly symptomatic because they would have presented earlier. And 2, the longer you're in atrial fibrillation, there's an expression AF begets AF, the more likely you are to stay in atrial fibrillation and the less likely you are to have a successful procedure. And then lastly, it's not maybe a reason not to do an ablation, but I think it's good, again, to remind people that this is a pathway to feeling better. It's a pathway to sinus rhythm. It's not a pathway to stopping anticoagulation. But I also tell people that if they shop around enough, they can undoubtedly find a doctor who's willing to stop their anticoagulation after an ablation. So who to refer? I guess I've kind of beaten this in, but symptomatic atrial fibrillation, people who really know when they're in and out of atrial fibrillation and their quality of life suffers when they're in atrial fibrillation. And those are generally very good candidates. So how likely is my patient to be successful? So probably the biggest factor is paroxysmal versus persistent. And that really just reflects sort of how deep into the disease state they are. Having a normal size atrium versus a huge dilated scarred atrium is a good sign. Younger patients, like every surgery, do better. And then the other factors we talked about. I think weight, fitness, and sleep apnea are particularly relevant because they're modifiable at the time, before, at the time, and after ablation. And that's my talk.
Great. I'll turn it over here to Sohail. I don't, let's see. There were some questions that came up, actually, Jared, and I don't know if you, of course, when you're giving a talk, you can't follow the chat.
Yeah.
So perhaps as if we do move on, if you want to kind of peruse the chat and see if there are anything in there that that you would address. I think a lot of it you did address, including, you know, when would you do an atrial ablation, the idea behind, not using aspirin. It's kind of useless for stroke with all the risks, as you said. One question that came up, and I think and I hope that it's addressed a little bit later by Doctors Miner and Rahim, is with regards to left atrial appendage occlusion and whether it has impact. Perhaps you can tell the story. Does it impact endocrine properties? Does natriuretic peptides change as you occlude or cause stretch in a vestigial organ?
Yeah, I'm not sure with Watchman specifically. There's another device called the Lariat device where we get sort of epicardial access, so go into the pericardial sac and basically tie a lasso around the left atrial appendage and tie it off. And it's been published in those patients that there's a big rise in BNP after that procedure. So I'm not sure with the Watchman specifically, but that would, maybe I'm being naive, but that would not be a long-term concern for me in either direction with a Watchman device.
I think there's
Great,
a
thank you.
take-home message that Dr. Gulati also mentioned, that successful AFib ablation doesn't mean that you should stop your anticoagulation.
Yes.
If you have a high CHA2DS2-VASc score, high risk for stroke, you should keep taking your anticoagulation. Dr. Gulati, do you have any comment or question for Dr. Miller?
Yeah, thanks for that great presentation. There's a lot of great questions coming up, but one of the things that you pointed out, I think you were showing the 2002 article and saying that, rhythm control versus rate control. But I was just wondering, we saw how poor we were at anticoagulation even then. Do you think we're any better at anticoagulation now with our newer therapies? Is there any data that we're doing a better job at reducing stroke? Just with these easy, simpler medications, I think.
Yeah. Well, I can say there's a lot of data showing that we can do better. So there's tons of case series showing, the quantity of aspirin prescriptions for atrial fibrillation is, greater than 0, I think would be unacceptably high. And it's close to, I want to say, well, I don't want to pick an incorrect number, but it's in the, tens of percents, of people in that regard. The rates of anticoagulation have gone up since the introduction of the NOACs as well. And then I don't know that I have data to support this, but I think the field's understanding that atrial fibrillation puts you at higher risk of a stroke when you're in rhythm when you're out of rhythm and when you're in rhythm is higher. And so whether it's AFib ablation or antiarrhythmic drug therapy, at least among electrophysiologists I interact with, I think there's understanding that the need for anticoagulation is there throughout.
And is there any data about weight loss after ablation in terms of if you lose weight, are you more like after you've done an ablation, are you more likely to preserve sinus rhythm versus somebody who doesn't lose weight, especially if they're obese to begin with?
Yeah, in Prosh Sanders' group, he's the guy from Australia who's done a lot of this work. I can't say about weight loss a year or two later, but his studies covered sort of the whole peri-procedural period. So the weight loss numbers were from before the ablation until after the ablation. So it's definitely, I think what was most impressive is that you can still be in the obese category, but if you're able to lose around 5 to 10% of your body weight, you're going to have a better result. And they broke it up into sort of quartiles of weight loss. And so the people who, lost less than 3% or gained weight were, no different than if they weren't enrolled in a weight loss program at all. And then as you went up in percentage of weight loss, the results were better.
And my last question is just, what do you tell runners who come in with AFib about as a runner, I want to know the future risk of them developing AFib even after you do these procedures, if they do undergo a procedure?
I think people have to balance, atrial fibrillation risk with what they really enjoy doing. I think on the whole, you're probably healthier doing that than not exercising. So I think I don't really discourage people from, doing those things that make them happy. So.
You discourage marathons?
Well, I don't think marathons are good for you for other reasons. I don't think they're good for your knees or your back or things like that. So, I think there's, it doesn't matter what form of exercise it is. If you take it to an extreme, it's probably not going to be good for you.
Great question, Martha. So for the sake of time, let's move to the next talk. As Jared said, that based on that NEGM study, that Eliquis is better than Coumadin in terms of lower risk of bleeding. So next, Viet is going to give us the brief overview of the DOACs. Yes, go ahead, Viet.
Okay, so let me see. Are you seeing my
Yes.
screen there? Okay, perfect.
Yes,
so, this is a review of oral anticoagulants. Let's see here. There we go. I have really no financial disclosures in relation to atrial fibrillation, although I have received honorary fees for Amarin. not for me, but our research department. So looking at, atrial fibrillation, oral anticoagulation, Dr. Miller did a great job reviewing risks of bleeding, covered the whole gamut with atrial fibrillation ablation. But for me, the goals for treatment really come down to, the scores are for population, and then the care is for the individual. So we have to remember that. Ultimately, the decision aid tools, Dr. Galati may have shared those already. But those are things that we need to go over with patients. Whether it's stroke, which is really devastating, or bleed, a major bleed, an event, that's also a major issue. So we really need to have these talks. So these targets for therapy, acute and chronic rate control, or rhythm control. You can see here, this is an old, a little clip from Dr. Grammer way back, and he's doing the AFib dance there, and assessing heart rate, and then managing risk factors. Here's, the American Heart Association's Life Simple 7, which, those same risk factors kind of fall in with stroke, atrial fibrillation kind of taking it over the top. And then from CardioSmart, assessing our patients, they may have these symptoms, and we may put it off to just age or one of the other comorbid conditions that they have, that makes the case for physical exam and potentially getting an EKG from time to time on your patients. So, what are these desired outcomes from therapy? We want hemodynamic stability, and then cardiovascular risk reduction, including that stroke prevention. So here, great movie, little clip from Med Movie, blood clot going on up to the brain. Okay, so oral anticoagulants, what could go wrong? Here's a clip from The Shining, right? Blood going everywhere. It's not benign, but certainly the hope is that we reduce risk of stroke. So here, you have a 50-year-old man presents to clinic for annual exam, and he's found to have an incidental atrial fibrillation, just found on exam, ventricular rate 60 to 80. When pressed, reports no symptoms, no medications, no established chronic diseases. You can see his vitals there. And so on your right, what you see is the CHA2DS2-VASc score. And the question you ask is what strategy would you elect? And I shouldn't have said rhythm, but rate versus rhythm. Does he warrant anticoagulation? Here's the CHA2DS2-VASc calculation. And then are there other studies that you want to take a look at in case you do anticoagulation, and could something else be driving this atrial fibrillation? So in this case, his age is less than 65, 0 points. Male, 0 points. That's it. I mean, he's 0 down at the bottom there, 0 points. Meanwhile, he is in atrial fibrillation. So do you anticoagulate? This is the question. Do you just let him kind of run around? And would you choose a rhythm strategy where you give him a chance at cardioversion? And then what? If he remains in atrial fibrillation, when do you anticoagulate, down the road when he reaches a CHA2DS2-VASc of greater than or equal to 2. So here, the quick review. When are they recommended? Well, Dr. Miller covered this. Off to our left, you can see greater than or equal to 2 in men, or greater than or equal to 3 in women. So the class 1 indication is to use anticoagulants when CHA2DS2-VASc is 2 or 3. So again, just reminding you that these are the scoring points within that CHA2DS2-VASc. I love Dr. Miller's extra questions of falling, alcohol use, those kind of things. So case 2 then, so you have the 65-year-old man who presents for follow-up of hypertension. He reports 2 to 3 weeks of palpitations, slight dyspnea, and general fatigue. He's on lisinopril, no other chronic diseases. And so you can see his vitals there. I did it backwards. I apologize. So again, the same questions arise, but in this case, he falls into the 65 to 74 range, 1 point. He's male, no points there, but hypertension history is +1. So he is at the greater than or equal to 2. And, all other discussion aside, whether you choose rate or rhythm, he is in that risk point of CHA2DS2-VASc that you would consider class 1 indication of anticoagulation, regardless of whether you choose a rhythm strategy or rate. So VK, here we go, warfarin and the DOACs, it's a band, right? So we'll look at this guy on the right. You know it goes wrong when the band's together and one has an accident. Here's warfarin. Just problematic. You're jamming along. Here are the DOACs, right? Apixaban, dabigatran, edoxaban, and rivaroxaban. Hopefully, the band continues to play on. Well, you know, with regards to warfarin, it's a moving target. This is problematic, and one of the reasons why it's moved, the DOACs have moved ahead in the guidelines. You know, it's INR ranges. You've got people coming in, they step on a crack, the wind blows funny, they happen to sneeze. INR is all over the place. Even after years of seemingly, you know, 2.1 all the time, something invariably goes wrong. Food interactions, drug interactions, but recognize that vitamin K does impact factors 2 and then 7, 9, and 10. And you know, let me not poo-poo it, because you still need to go back to warfarin if someone has atrial fibrillation and severe mitral stenosis or mechanical heart valves. You have to go back to it. So it is something that we still use and still manage, but now we have a smaller population that we can really take care of, rather than everyone on warfarin and Coumadin clinics, etc. So going through the DOACs, just a quick physiologic review. Here's warfarin up at the top left of this, and you can see that it's where it impacts of 10, 2, and 7. And then you'll see over here where dabigatran falls in. It is a factor 2A impactor right there, and then factor 10As are up here. So these are the 4 direct oral anticoagulants and where they sit within the cascade. So here, you know, just a reminder that the 2019 update of the 2014 guidelines, here are the NOACs. They are recommended over warfarin. So, you know, that should be DOACs in those that are eligible. So again, no severe mitral stenosis and mechanical heart, no. Class 2 for those that show up, just like our cases where 48 hours duration or longer, if you're gonna, you know, start an anticoagulant, before cardioversion, then at least 3 weeks before and 4 weeks after the cardioversion occurs. And then lastly here is under 48 hours. If they show up right at the exam, then again, do your CHADS-VASc, and then you can administer one of these heparin, factor 10A inhibitor, or direct thrombin, these 4, before the cardioversion. So coming back to case 3, I didn't change this. This is, well, okay, the picture's off, but it's a 67-year-old woman presents for follow-up of diabetes. She started having palpitations while sitting in the lobby and states this occurs 2 to 4 times a month, lasting 1 to 2 hours. On lisinopril, 20 milligrams, metformin 500, and atorvastatin 20. She has no other chronic illnesses. And so again, the questions come up, and this is someone that's just popped into clinic for diabetes, but has symptoms right then and there, reporting this paroxysmal type of reality. So EKG, of course, is helpful here. But, you know, the age, here she gets 1 point. Female, I'm sorry, I missed that right here, is +1. I mean, sorry, but sex counts here, and females add 1 point, and that's why it's greater than 2, 2 or greater than 2 for men, and then it rises to the 3 level for women because they have that as being female. Diabetes history +1, so 3 points, and this is someone that you would consider or recommend anticoagulation in. Coming to this, I know it looks a little busy, but as we follow along on this left side, the trade names, of course, if you're familiar with that, I use generic names because eventually they will go generic, and that's how I remember them. But dabigatran, rivaroxaban, apixaban, and edoxaban, really, they're not in any recommended order. It's actually FDA order of when they were approved. So there's that little bit of history. The dosages differ because they're kind of different formulations. You have 2 of them that are BID, apixaban and dabigatran, and then rivaroxaban and edoxaban are both once a day drugs. Now you have to adjust the dose to the kidney function, and I've given that here, going from 150 to 75. But definitely not recommended for less than 15 on the creatinine clearance for dabigatran, and then rivaroxaban 15 you can adjust down to, but less than 30, we just don't have it, it's not defined by the studies. Remember that a lot of the paucity of data that we have is because of how the trials were created and who was excluded. So, that's a little problematic, but I'm sure we have some retrospective or observational data that's accruing as people use this in the real world. Apixaban here, again, it's you reduce from 5 to 2.5 as you factor in 8, any two of the 3 factors if they're present: age greater than or equal to 80, weight less than 60 kilos, creatinine greater than 1.5. And so, pay attention as you have these patients on these, as they're near those kind of lines, near 80, or their weight, they're tinier. Creatinine is, if they have some acute or chronic kidney disease, just pay attention to those and adjust accordingly. Lastly, edoxaban. Again, oddly enough, this is one that has 2 not recommended, where the creatinine clearance, if it's less than 15 and then it's greater than 95. And what was happening is they actually saw a lot more strokes in those individuals. So some clinical pearls, GI bleed is an issue here, right? We're in a population that does have GI bleeds. And so avoid dabigatran in those with high risk of GI bleed or peptic ulcer and dyspepsia. Also, rivaroxaban and edoxaban fall into that GI bleed risk. Apixaban does not have that issue, and there's less associated major bleeds for those that have reduced kidney function or creatinine clearance. And so a lot of my patients end up on apixaban because of that. Creatinine clearances are generally poor. They have more GI bleed history in this population. So I generally gravitate towards apixaban, but it's nice to have a once-a-day drug here in edoxaban and rivaroxaban. You might ask, are there reversal agents? Because, Coumadin and warfarin, we're always thinking, well, it's, vitamin K and anything and everything messes it up anyways. How do you reverse the DOACs? Here we have Praxbind that's specific to dabigatran, and that's an IV infusion. You have some non-specific reversal agents, and really what they do is they supplement upstream factors to kind of overwhelm that binding that occurs from the DOACs, and so they're listed here. However, there now is an FDA-approved from 2018 Andexa or andexanet alpha, which is a decoy molecule. So instead of binding to factor 10A, it binds to this decoy molecule, and it binds more. There's a higher affinity to this decoy molecule, and so it helps to reverse the effect of the DOACs here, both in apixaban and rivaroxaban. And then lastly, with edoxaban, there's no specific reversal agent there. It's these non-specifics. I apologize. That's a real quick overview, but I wanted to keep us kind of closer on time. I'll kind of open it up to short questions here. I haven't been following the chat, so let's see here. Come back to this.
I think, Viet, let's keep questions to the end of the session so that we can finish 2 more talks, and then we'll have whole 30 minutes for questions and answer session.
Great. I'll stop sharing there.
All right. Thank you. So let's move on to the next debate session. As I said earlier in my comments, that the Watchman device has class 2B indication per ACC guidelines for patients with AFib who have contraindication to take anticoagulants. But as I mentioned, that the way it is promoted in the ads, even for those patients who don't want to take anticoagulants for high risk like physical activity or so I think that not all centers, but some centers is being overused. And the other issue that I have is that even so-called patients who are not candidates for anticoagulants because of bleeding risk, they still have to take Coumadin for 45 days. post-procedure and dual antiplatelet therapy for 6 months. So are there really high bleeding risk? So I really have those questions, and we have two great speakers today. So I want to start off with Dr. Edward Miner. He is interventional cardiologist at Intermountain Heart Center. He's a very good friend, and he's going to talk about Watchman device. And his title is Patients Who Have CHA2DS2-VASc Risk of More Than 1 with Bleeding Risk Should Get Watchman Device. Dr. Miner?
Thanks, Sohail. Thanks for organizing this. I appreciate the chance to speak today. Let me figure out how to share my screen here.
Viet, can you let him do that?
Yeah, so it should be on share function there, Ed. The thing would be is once you hit share screen, it will pop up with multiple screens if you happen to have other things up. There we go.
Got it, okay.
Yep.
Very good. So, well, thanks a lot. This is great, Sohail. Thanks for organizing this, and appreciate the chance to work every day with great people like Jared Miller and Viet. You guys make me feel old because I remember exactly where I was in 2002. I was a resident at Mayo Clinic hanging out with Jared Bunch, my good friend that I worked with for like 17 out of 20 years. And when Jared left, I was so angry I didn't anticipate we'd get another Jared electrophysiologist who's just as good. So it's so great to have you, Jared, working at our hospital. So this is where I work, Intermountain Heart Institute at Intermountain Medical Center. And you know, we've had been very, very involved really in every one of the landmark Watchman trials. And I have sat every day in clinic every Tuesday with Brian Wisenant, who's been really an important doctor for the Watchman device. And I was very skeptical. He talked to me a few years ago into getting involved. And so I'll talk a little bit about Watchman. So I want to talk about patients, the theoretical world and the real world. One of the docs I worked with is named Michael Minder, and he gave people a survey. Our office got confused, and they were giving every patient a survey, and it said, tell the doctor honestly what you think about your medicine, something like that. And here's where a few of my comments. I didn't want this to go to my patients. I'm not that conscientious, but it accidentally went. And these were a few of the comments. I'm worried about all these toxins I'm putting in my body. I stopped filling and taking my Eliquis because I hit the Medicare donut hole in August each year. I'm embarrassed about how my skin looks. I can only wear long sleeve shirts. I'm so bruised. I can't afford all the expensive medicine the doctor wants to put me on. My mother took warfarin and bled constantly. I don't want that. I wholeheartedly agree that the DOACs are superior to warfarin. And one smart patient who's a pilot, a smart guy, said, well, I take Eliquis once a day. That's a good way to save money, make it last longer. The other thing in these trials is any cardiovascular trial, if you look at bleeding risk is associated with death. If someone showed me any cardiovascular trial and wanted to know in advance which group would do better, I'd say, well, which group's going to bleed more? We all know anticoagulation is protective against coronary and stroke events. Even warfarin in patients in the absence of AFib is protective. We don't recommend it though. Why? Because of increased bleeding risk and increased mortality risk. We know through the 80s and 90s that thrombolytics were proven to be inferior to PCI because of bleeding. STEMI patients who get randomly assigned to femoral access bleed more and die more. There was a study of bivalirudin that showed that patients bleed less and die less if they get bivalirudin compared to heparin plus 2B3A inhibitor. Of course, this recent WOAS trial that showed that triple therapy is bad, that if patients need anticoagulation and get a stent, for example, a coronary stent, they should have clopidogrel and anticoagulant rather than triple therapy. They should not receive aspirin in that setting. And rivaroxaban, intensively studied medication that Viet just reviewed very well as one of the options for the DOACs. And everybody knows that this rivaroxaban is going to prevent vascular events. So it was tested a lot of different doses, studied extensively, And the sweet spot, as it turns out, is a tiny dose, 2.5 milligrams twice a day. Anything more than that, and you get excess bleeding that negates any benefit. And one, Brian and Wizenat and I, as we've done 2,000 TAVRs over the last 11 years, we many times looked at each other and said, boy, these TAVR patients, they probably should go on a DOAC. Wouldn't that be the right thing rather than aspirin Plavix? Well, that was studied, and even a half dose of rivaroxaban dramatically increased deaths. The study was stopped early because of 60 some odd deaths in the rivaroxaban group and only 38 deaths in the antiplatelet group. So these DOACs, as good as they are, they can, in the right patients, they cause problems. This has already been reviewed, so I'll go through this quickly. Patients with men with a CHA2DS2-VASc score of 1 or less, women with a CHA2DS2-VASc score of 2 or less do not require anticoagulation, and many of them already have a reason to take aspirin, but I wholeheartedly agree that aspirin should never be recommended for stroke prevention in AFib. And Sohail went over this very well, that 2B recommendation is out there for left atrial appendage occlusion. I totally agree with that recommendation as a 2B in that spot. That's really the level of evidence. This has been discussed, this CHA2DS2-VASc score. There might be some, if you look at data like this, maybe aspirin has a very slight benefit, but overall, totally agree that really you need anticoagulation to reduce the stroke risk as the CHA2DS2-VASc score goes up. Has-bled score, I agree. You never see a high CHA2DS2-VASc score and a low has-bled score. These problems track together. As the CHA2DS2-VASc score goes up, the has-bled score goes up. Now, Martha talked about this, and one of the crazy things in the community is how many patients are out there. Now, of course, Jared's patients and my patients, I think, tend to be on anticoagulation. But if you look at just everybody in Utah with AFib, the chance of being anticoagulated is low, and maybe around 50%. And I tell you, I see so many patients followed in the community who say, well, my doctor and I talked about it, and I just take aspirin because that's easier. And so the reality is a lot of patients won't take these blood thinners, don't take these blood thinners, are looking for alternatives. And when you start patients on warfarin or a NOAC, we know for sure that they stop them. As much as I think my patients love me and are going to do everything I tell them to do, we know statistically that's just not true. People stop their warfarin, they stop their NOAC. And if you look at pharmacy level data of patients prescribed apixaban, rivaroxaban, dabigatran, warfarin and with a permanent indication, we know that maybe around half of patients are proven to fill it with 80% or greater adherence. So there's no doubt in a real world setting, patients don't want to take these drugs. And in studies, you can see discontinuation rates of 20% or more, and bleeding risks that were well characterized. I do think apixaban is the safest as far as major bleeding risk in the majority of patients if you have to choose one, but the bleeding risk is there, and adherence is not great. The other thing I encounter on a weekly basis, today I had a patient say, I have AFib, my primary doc started me on a blood thinner, and just to be safe, he gave me 2.5 BID of Eliquis. And this is a man who is 65 and healthy, and he's like 6'4", 200 pounds. He's about my size. It's crazy to be on a reduced dose of Eliquis, but in the real life, this is surprisingly common that people will initiate these drugs at lower doses than recommended in an inappropriate way. I'll skip through some of this. So the Watchman is out there. It's a 2B indication. I think it's a small percentage of AFib patients that are appropriate for a Watchman, but when they are implanted, we recommend anticoagulation for 45 days. a TEE is done to evaluate the device. Then they receive aspirin and Plavix, and then long term they receive aspirin. The vast majority of patients we would use this device on have another indication for aspirin. So I agree with this idea that aspirin is not indicated for stroke prevention due to AFib. And this Watchman has been extensively studied. We did our first implants at LDS Hospital in 2005, and they've really, there's a long history of studying this device. FDA approval occurred in March of 2015. The patients are all followed carefully in registries. Procedures become safer over time. In the early experience, there was a risk of a adverse event that was 9.9% in the first half of PROTECT AF, declined with subsequent studies, and even in the second half of that study. There are techniques that are being used. This is the sheath going across the septum. A pigtail catheter is frequently put in this sheath to protect the appendage from injury as that sheath is advanced into the appendage. And this device that comes in different sizes can be deployed in the left atrial appendage and can effectively prevent any left atrial appendage clot from leaving the appendage. The patients we're currently implanting are followed very closely in a registry. FDA's mandated this registry, and these patients are being evaluated for stroke, death, systemic embolism, safety endpoints with the procedure, which I agree is extremely important. The one interesting thing that's come out of this registry data is there's this idea that, well, you're rolling it out of the academic centers to the community, surely the complication rate will go up. Actually, in the real world setting, the complication rate has been extremely low, and perhaps even lower in the real world than it was in the studies, which is a topic for a different day. But this can be done in the community setting in a very safe and effective way. So very smart people disagree on the Watchman data. If you look at the really smart cardiologists I know at Mayo Clinic, you have David Holmes and Bernie Gersh. David Holmes thinks that is a believer in the Watchman data. Says you reduce mortality, patients with bleeding risk need a Watchman device. Bernie Gersh and others, and my good friend Jared Bunch are more in the camp of saying, well, I'm not sure anybody needs a Watchman, and if there is anyone who needs it, it's a very small group. The data that were presented to the FDA for approval and that CMS agrees that that can be paid were meta-analysis of these two studies, PROTECT AF and PREVAIL. We enrolled patients in both of these studies at Intermountain Medical Center. And if you look at the outcome, the efficacy data, which is a combined endpoint of stroke and bleeding, was neutral, which I think is the reason there's a 2B indication. There are no data that say there's a patient who has to have a Watchman. But the expected outcome was a huge decrease in hemorrhagic stroke, actually a significant decrease in disabling or fatal stroke, and a statistically significant decrease in cardiovascular or unexplained death, and actually even in all-cause death. There's no doubt warfarin prevents strokes that do not come from the appendage. I think that's clear. So what you get when you put in a Watchman and you stop warfarin, you do get a slight increase in non-disabling strokes, but you get a decrease in hemorrhagic strokes, fatal strokes, and an overall risk of disabling stroke goes down. And the thing that finally, I was a skeptic with Brian for years about the Watchman procedure. And I told him, why would you put this thing in the heart? Patients aren't going to feel better. I want my patients to come back and say, I can breathe. I'm not having chest pain. Why do you put this thing in there? And, you know, I was finally worn down by just the evidence from multiple trials that to me passes the sniff test. The ischemic stroke rate is low, and there's no doubt in my mind it's lower post-Watchman device than it would be in these high-risk AFib patients who without any anticoagulation. This evolution trial is a trial from Europe and the Middle East, and the annualized ischemic stroke risk was 1.3% in a group with a CHA2DS2-VASc score of 4.5 that were not treated with any anticoagulant at all. These patients mainly got a Watchman and aspirin Plavix and had a remarkably low ischemic stroke risk. So I think overall the Watchman in the right patients passes the sniff test. David Holmes beats this drum about the mortality reduction. I think that's real. And this is David Holmes just published this a few months ago, which was a continued access protocol that we enrolled a lot of patients in after Protect AF and after Prevail, that showed an expected stroke risk of 5% or 7% that was 1 to 2% post-Watchman. So I do think it, as a 2B indication, Watchman can make sense for patients. They have to have non-valvular AFib. They have to have increased risk for stroke. They have to be able to take short-term warfarin. I tell you, I know you guys made fun of skiing, but there are patients who are crazy skiers and crazy cyclists in Utah. And I tell you, if sometimes I'll say to people, if they really want a Watchman because of skiing or cycling, I say, well, let's go together. I'll watch you and then we can decide. But there are no doubt patients that put themselves at very high risk with the crazy outdoor activities in Utah. I'm going to skip this for the sake of time. This is hot off the press, though. Small study called PROG 17 that randomized patients to DOAC or left atrial appendage closure and aspirin Plavix. The patients in this red line never received any anticoagulation, and they received only aspirin Plavix, and they had similar outcomes to being on a DOAC. And this is too small a study to draw a lot of conclusions, but a point estimate again that shows lower risk of death. So summarize, sorry if I've taken too much time. I think for Watchman, good patient selection is the key. We get a lot of referrals for patients that I would consider terminally ill. They don't walk, they've had recent bleeding, and you know, these patients we turn down. They're not going to have enough time to benefit. Good patients are those with poor compliance, patients with a strong need for Plavix and aspirin. I do believe that patients who just say, I'm never going to take a blood thinner, can be offered a Watchman if they really feel very strongly about that. The permanent AFib patients, I love to close a patient who had a resolved left atrial appendage thrombus. I think that's a patient who's shown they can form a big clot in the appendage, and once it's gone, I think if they are poor anticoagulation candidates, that's a perfect patient to close. This procedure is very safe at experienced centers. This was covered that post-Watchman strokes are less severe, and DOACs at the AFib doses are not benign. They increase mortality. And even at the 10 milligram dose, the TAVR patients died a lot fast, 10 milligrams of Xarelto. So as great as they are compared to warfarin, I do not believe these DOACs are benign drugs. This is an actual text I got from a professor at BYU who rides his bike like a maniac and has AFib and got a Watchman last year. Hi, Dr. Miner. I thought you should know I was in a bike versus car accident last week. They call my injuries serious but not surgical. I have a traumatic brain injury, double blurred vision, cervical spine fractures, tears, and contusions. I'll be in rehab through July. I'm wearing a neck brace 24/7. So grateful for the Watchman device. Such a blessing. Please review my record. This is a man who was just on aspirin, and I think would be dead if he had been anticoagulated. We're enrolling in trials at Intermountain Medical Center. We're the leading enrolling site in the Watch TAVR trial, where patients undergoing TAVR with AFib either get a TAVR alone or get TAVR plus a Watchman device. And based on that Galileo study where rivaroxaban increases the risk of death after TAVR, we're pretty optimistic that this would show a benefit to the device in these patients. And then I was very grateful to hear Dr. Miller say that post-ablation patients should just still be permanently anticoagulated, because we might be approaching some of these patients about being randomized in the option trial, which takes patients who get an AFib ablation and they either get permanent anticoagulation, which is of course the standard of care for higher risk patients, or they get a device occlusion, which with the next generation Watchman Flex device, and stop the anticoagulation. Thanks.
Thank you, Dr. Miller. Do you mind going back to that slide where you have all the indications on one slide? Right here. Next.
Right.
Okay. So, Dr. Gulati, are you there?
Yep, I'm here.
So, Class 2B indication, patients who are high risk for bleeding due to anticoagulants. And what are your thoughts on Watchman implantation on these other indications, for example, cognitive impairment, severe renal failure, or occupational lifestyle with increased bleeding risk? Would you refer your patients for those indications? And Dr. Miller, this is also a question for you.
So to some degree, yes. My question actually that I was going to have for Ed was related to, so we have patients that can't be on anticoagulation. I'll refer them to my electrophysiologist, one of which we've stolen from you. And when they do Watchman, they take away, they have to be on anticoagulation for 6 weeks. And yet I am sending them a patient that I believe can't tolerate any anticoagulation. So that's always been a little bit of my hard part with Watchman, because I still have to let them be on it for 6 weeks. And I just wondered how you deal with that, because that is, I guess, my hesitation in saying, yes, I refer them. I certainly do, but I don't always know if I'm doing right by them. I think that, yes, I see that, younger people don't want to be on anticoagulation and for their lifestyle reasons, but I know they can actually tolerate 6 weeks of anticoagulation. I don't have as hard of a time with them, but my little old ladies that I do have, I've had a few bad outcomes. So I guess I'm a little more wary about them. And then when I send them to EP for really help me with management, they suddenly might get a Watchman, and I have a harder issue with that.
Yeah, great questions. I think every patient is unique, and this can be very challenging. And I think it's true that you have to track these patients over time and maybe figure out the timing can be really important. I get called all the time about patients who are active GI bleeding in the hospital, and of course that's a patient you can't do anything with for a few months usually, and but maybe has risk of recurrent bleeding. And so we do keep a spreadsheet and try to track these patients so that we can let them recover from their bleeding event, find a 45-day window where we feel they can be anticoagulated. Part of the story in this Prague 17 study just published within the last week or two, those patients were treated with aspirin Plavix only after device. And that's, of course, totally off-label and not recommended. But in a lot of centers in Europe, the patients are treated without ever starting anticoagulation. They get a Watchman and take aspirin Plavix. And the risk of device thrombus or stroke is not high with dual antiplatelet therapy. It still is quite low. But the standard is anticoagulation. So our general practice is to try to find a 45-day window to do it. Hopefully people are doing this in very close consultation with primary physicians, primary cardiologists. I think that's so important to do this thoughtfully. And I agree. If this procedure is done in a way that's not thoughtful, it can be hazardous and put the patient at more risk. Clearly.
Somebody
put
also
a-
asked a question, and I wondered if you knew the answer to this. So if someone refuses anticoagulation and has no contraindications, will the insurance cover the cost of a watchman?
Oh, that's a great question. So you have to have Medicare wants documentation of shared decision making, and I do think these are all taken. All these examples I've listed here, these are examples that were brought up to the FDA, and in the FDA approval, and CMS is aware of these. I do think as long as a shared decision-making discussion has taken place. Now, of course, our job as physicians is to tell the patients what they should do. But at the end of the day, if a shared decision-making discussion has been made, I think it can, and the patient is aware of risks and benefits, I think there is an option for poor compliance, inability, or refusal. One common misconception that referring docs will say is, oh, you have to wait for severe bleeding. They have to have had a blood transfusion or some massive bleeding event. And that is definitely not true. That there's nowhere that says, does a patient have to bleed first in order to have Medicare coverage or other insurance coverage.
Thank you, Dr. Miner. It was a great talk. Now we are going to invite Dr. Rehan Karim. He's an electrophysiologist from University of Minnesota. And his talk will be on not every patient who has CHA2DS2-VASc score more than 1 with increased risk of bleeding should get Watchman device. Dr. Karim.
Okay, thank you. Thank you so much. Let's see if I can see the screen here. Let's see. Can you see this?
Yes,
Yes.
we can.
See if I can play the slideshow. And can you see the slideshow?
Yes, we can.
Perfect. Give me 1 second. All right. Well, thank you very much for the invite. I'll try to stay within time, 15 minutes. This was a great talk. Unfortunately, I do not have any patient anecdotes and patient comments, so I'll try to stick myself to both real world and trial data. I'll be talking against the motion that everyone with AFib and CHA2DS2-VASc of 2 or more and a bleeding risk should be getting a Watchman device. I do not have any disclosures related to this talk. So let's start out with a similar case that was just some of the cases were presented. 66-year-old retired executive. He had a pacemaker placed some years ago for symptomatic pause. Other than that, he has a history of hypertension, which is fairly well controlled with amlodipine. And you can see this data. You can see this pacemaker. Let me go back here. It didn't start out. Sorry for that. All right. You can see this, graph over here. He had quite a few episodes of device-detected AFib, not 10, 20 seconds, but several hours of AFib per day. Other than that, he's fairly healthy. He does mountain biking, and he's worried about risk of bleeding. He saw a TV commercial, and he basically wanted to find out if he should get a Watchman. As you can see, his CHA2DS2-VASc is a score of 2. So let's take a look at a few things. Let me see. Just a second. I think you can see both the screens. So let me try to unshare this for a second and start it in a different way. Sorry for that. All right. For some reason, it is only, let me just share from a single screen. All right. Can you see it okay? Okay, thank you. Sorry for that. All right. So I will basically focus on 4 things. Okay, I'll talk about the stroke risk in contemporary era. I'll talk about the risk stratification schemes that were just discussed, just a few nuances about that. I'll talk about some data from the Watchman device trials itself, and a little bit about competing risk of stroke. So we all know this all started out with Framingham study, which showed that atrial fibrillation increases the risk of stroke, and that increased interest in antithrombotic therapy, and it paved way to several trials, which basically showed that atrial fibrillation, non-valvular atrial fibrillation, when treated with anticoagulation, that reduces the risk of stroke, and at the same time increases the risk of bleeding. And then basically there's a sweet spot between the INR of 2 to 3, where it has a net clinical benefit to reduce the risk of strokes. Just a second. All right. Okay, so the key points from these randomized clinical trials, they basically established the role of anticoagulation, but not only that, they also eliminated the use of placebo groups from any future trials and established warfarin as a comparator for any future studies. And that's basically what we saw for the DOAC trials and also for the Watchman trials, that essentially they had to be compared with warfarin. We could not use placebo anymore. Now, let's take a look at contemporary risk of stroke. This is Medicare data, and risk of ischemic warfarin use over a period of time. So this is from 1992, early 90s to 2000s. The risk of the use of warfarin has gone up, and at the same time, the ischemic strokes have gone down, and basically hemorrhagic strokes have kind of sort of stayed the same. So this is great. The warfarin use has gone up, the ischemic strokes have gone down. But if you dissect the data even more, not only the strokes in anticoagulated patients have gone down, but even non-anticoagulated patients, the stroke risks has decreased by half, almost half. And so the same data over here, you can see that warfarin use gone up, stroke risk gone down, almost parallel, both in anticoagulated as well as non-anticoagulated atrial fibrillation patients. And trial after trial, we've seen the same result. DOAC trials have shown decreased risk of strokes overall compared to equivalent CHADS or CHADS-VASc score. Data from PREVAIL actually showed that ischemic strokes were higher in the device group rather than in the control arm. There was only one stroke or systemic embolism in the control arm. And in fact, the risk of complications was much higher than the actual risk of stroke. So, and then that was short-term, long-term CAP registry, almost 4% of them had device-related thrombus. So let's get back to our patient with multiple episodes of reasonable duration of atrial fibrillation. And there is data about that. A third trial, it clearly showed that, well, as expected, there is increased risk of stroke if they have atrial fibrillation compared to when they don't have atrial fibrillation. But let's take a look at the numbers a little closely. 1.7% in non-anticoagulated patients who have that risk. Their median CHADS-2 risk score was 2.2. And historically, all those comparison slides were shown. If you look at the historical risk of stroke in those patients, it was between 4 to 6%. All right. And study after study, trend study, I will not get into the details, but just a statement. The study was terminated earlier than planned because observed rate, event rate, was too low to achieve primary study aim, which was planned by the termination date. So, and again, we have data from cohort studies, we have data from population-based studies, and these trials. Now let's get back to the risk factors. Our patient who had hypertension, there is data that those who have well-controlled hypertension, their risk of stroke, this is sportive trial, showed that their risk of stroke is much less than those who don't have a well-controlled hypertension. Let's switch gears a little bit and look at the CHA2DS2-VASc scheme. This slide was shown earlier by one of the presenters, and this is the original data where CHA2DS2-VASc scheme was proposed. And take a look here. CHA2DS2-VASc score of 3 is of 4%. Double the CHA2DS2-VASc to 6, the stroke risk is 3.6%, less than that. Look at CHA2DS2-VASc score of 4, risk of 1.9%. This is the original study. Now, the other slide which was shown is from the Swedish validation study. So this was the original data. And then they had a huge 25,000 plus, I believe, study, which has its own issues. But I'm just for comparison. C statistic for these studies was 0.6. I'm not a statistician, but essentially if C statistic is 0.5, that means it's a flip of a coin. So C statistic of 6, based on that, if we are making that type of a lifelong decision. Now let's look at the contemporary data. So this is last year published in Circulation, a huge data set from claims data, I believe, from Optum, thousands of patients, Circulation. These are AFib patients which are not anticoagulated. So these are not anticoagulated patients. It's a busy slide. I will not look into all the numbers, but let's make a comparison here. All right. So on the left side is the contemporary data. On the right, this is the Swedish study. So if you punch in the numbers in the app, these are the numbers which are spit out. And let's compare CHA2DS2-VASc score of 3. All right. CHA2DS2-VASc score of 3, risk of stroke, contemporary data, almost just 1%. You look at this study where we make all these comparisons, 4.6%. Double the CHA2DS2-VASc score, it used to be 13.6%. And in the contemporary data in our patient, for example, it's 2.1%. So this is clearly different. And we can go into the details why, but it's, I think, outside the scope of this 15-minute talk, why the numbers are so different. But let's now switch the gear and look at the Watchman data itself. There are multiple issues with the Watchman studies, and we'll try to sort them out quickly one by one. Non-inferiority margin. Both PROTECT AF and PREVAIL used a non-inferiority margin of 2.0 and 1.75. Higher the number, easier it is to achieve the non-inferiority limit, okay? Compare that with the RELY and Aristotle data, is 1.45 was the non-inferiority margin that was used. Death as a composite outcome. Death is a rare event as shown by those trials, okay? DOAC trials use stroke and systemic embolism. Death, as I said, is a rare event and it favors non-inferiority. So when you're combining that, it's essentially a statistical game that is being played to show the numbers. All right, let's look at the ischemic versus hemorrhagic strokes. All right, let's look at the numbers. As I earlier mentioned, the ischemic strokes were actually higher in the Watchman side than on the DOAC, than on the warfarin side. The benefit was primarily because of reduced hemorrhagic strokes. Now, this hemorrhagic stroke rate of 1.1% was actually higher than usual numbers, and essentially with these very low absolute numbers could easily have been a statistical chance, and there is reason for that. Let's look at the other data. PREVAIL, the anticoagulated patients showed a 0.5% risk of hemorrhagic stroke. DOAC trials with more than 40,000 patients showed 0.36 to 0.5% risk of hemorrhagic stroke. So that PROTECT AF was clearly just by chance. Other than that, there were several adjudication irregularities which happened with hemorrhagic stroke. And this is again from FDA executive summary, FDA data. This is online, this is public information. When the FDA reviewers looked at the data, patients who had falls and resulted in subdural hemorrhage, they were adjudicated as hemorrhagic strokes. On the Watchman side, patients who had a fall and had subdural hematoma, those were not adjudicated as hemorrhagic strokes. Adjudication of death was an issue. PROTECT AF had a spuriously low risk of death on the side of the device side of things. PREVAIL data was not consistent with that. FDA inspection, and this is again a copy paste from the FDA document, which is available online, that numerically these cardiovascular unexplained deaths, they actually favored the Watchman side. But when they looked at those deaths, those were not attributed to the device or to the anticoagulant therapy. Those deaths were just by chance and very few in numbers. All right, PREVAIL we already talked about. It did not reach non-inferiority. Overall numbers were numbers were very small. Question comes, is the bleeding risk really lower in these patients who have Watchman device? Again, this is real world data, CAP registry. This is real world data, FDA document again. Their overall risk of bleeding, and these are not anticoagulated patients anymore. So despite, because they have a Watchman device, so now they are not long-term anticoagulated, and they had a 13% risk of major bleeds, annualized to 4% per year, right? Device-related thrombus, we already discussed that. CAP registry, 4%. Evolution data, 4.1%. They continue to have that. Risk of adverse events, almost depending on what kind of study you take, 13.6% in an observational study. Well, you can argue that that was the initial phase. As the time passed by, it is different. You average out 4 large trials, it's around 6%, much higher than actually the risk of stroke in the contemporary data. So now you are comparing that risk of serious adverse events with the contemporary data from new lower risk of stroke in those patients. And again, you talk about the data from the DC cardioversion, which was recently published. These patients, even the implanting doctors, they were not confident enough that it's going to reduce the thrombus. That's why they wanted a TEE in every patient, right? We don't do a TEE in patients who are on anticoagulation for over a month. And they found device-related thrombus in those patients. In fact, almost 60% patients required anticoagulation. So even the implanting physicians were not confident enough that this is going to reduce the risk of stroke before cardioversion. And the last just 30 seconds, a competing risk of death. Question was brought up about renal disease. And so essentially it's a lifelong treatment, either anticoagulant or Watchman device or any therapy is a lifelong treatment. And there is a competing risk of death. And essentially for the same reason, we do not put an ICD in somebody who has a long life expectancy of less than a year. It is contraindicated because they have a higher chance of death before they have a chance of a death due to other causes. And these are very short-term studies. So I'll just show one example for the sake of time. This is the data where they looked at the time to death or competing risk of death analysis in elderly patients. Now, some people may get offended with their definition of elderly. It was 65 years and above, but essentially, median population was median age was around 80 years. So this clearly shows that the risk of death before they get a stroke is actually 9 times higher, 9 times higher risk of death before they even have a risk of stroke. So in that situation, now you are talking about a lifelong, therapy. with unknown long terms, that becomes a challenge. There are other data also regarding renal patients, but again, for the sake of time, I'm not going to discuss those. And that's why essentially ACC, AHA, HRS did not give it a higher indication. It was essentially 2B and not 2A or not indication 1. So to summarize, the net clinical benefit of this Watchman device in non-valvular AFib, it may be limited due to declining ischemic stroke rates, due to better risk factor mitigation. There's some data about diabetes also, again, I did not share. More patients being identified with low risk subclinical AFib. So yes, they are longer AFib episodes on the device, but they are still subclinical AFib, and there's enough data about them. And less than ideal risk stratification strategies. Unconvincing, unimpressive data from Watchman trials, flaws in the study design, adjudication issues, discrepancy between the studies, low event rates, continued need for anticoagulation, adverse event rates, which are higher than the risk of stroke. And again, the competing risk of death should be taken into account. So I will conclude here, and any questions or anything, certainly we can open it up.
Dr. Karim, we can definitely see you are a numbers geek. I mean, you really teared apart those trials. That's why we have Dr. Gulati here, who is going to moderate. So Dr. Gulati, what is your first impression hearing this talk?
Well, I like, I think, what we could say just as a moderator, I would say, I think that you both, Ed and you both gave a really nice way of saying almost the same thing, in the sense that you got to take the patient in front of you into consideration, weigh the risks. Like you said, I mean, the data, you always have to look at the studies and see who's enrolled and look at the numbers. But I heard from Ed very nicely, like it's the patient in front of him that he has to make the decision on, and doesn't take the device to be, lightly. And I think that's the role, with the ACC, we really tried to make those tools easy for all of us, the shared decision-making tools, which are part of this. And I think that, you've emphasized why that's important, because even the things that I think don't always get discussed are the risk of thrombus, for example, after we put in these devices. And patients really do need to know what they're signing up for when you're offering them. So, I was just wondering how you both could maybe explain to us how you use shared decision-making with your patients. We've sort of heard it a bit from each of you, but how you share this information and the limitations of the study.
I loved your point about the complication rate and how important, in my mind, it's so important to avoid complications in these patients. That these are healthy patients. This is not someone having a heart attack. This is a healthy patient who checks in, hoping they're going to get something that improves their quality of life, reduces their need for blood thinners that can harm their quality of life and even end up getting them hospitalized. And these procedures have to be done safely, and that's a big component of this, no doubt. And patient selection, performing the procedures without any complications, and this goes to kind of a wider issue of what is informed consent. Can a patient really understand? And if a patient says, well, I hate these bruises on my arms, is that, and I'm not going to take a blood thinner for that reason, I'd rather have a stroke. Well, how do we talk to patients? So I know that it's very important, and to make sure we're trying to just describe the procedure, describe the risks, describe what we don't know, and what we do know. The statistics are interesting. You mentioned, the Prevail warfarin group did amazingly well, which and we know real world patients on warfarin don't do as well as that Prevail warfarin group. That was a statistical aberration that actually caused warfarin to not meet the non-inferiority in that Prevail subset only. And so there are statistical outliers when you talk about a relatively small study like Prevail that you have to take in the context of what we know more broadly about warfarin and its risks. And I just think, I really hope this option trial can get off the ground. This COVID pandemic has just, right when the option was getting going, it just sunk it around the whole country. So if we can get real world data on ablation patients, on DOACs, modern patients undergoing AFib ablation, and some more randomized data, I think that'll be very helpful in knowing what to tell patients.
Yeah, I think these are great points. I think the bigger challenge comes with regards to shared decision making. A lot of times patients come and they basically ask, doc, whatever you say, what do you think is the right thing for me? And that becomes a bigger challenging point. If they're able to participate in a discussion, we share the data and say that this is what it is. The litmus test is that if it is me or if it's my family member in that situation, would I want to have that done? And I can tell you, looking at the things a little critically, especially if you look at, I agree with your point that Prevail was also some degree of an aberration. But the issue is that the theme is pretty consistent. You look at the DOAC trials, you look at the device subclinical AFib, you look at the ASSERT data, you look at the trends data, you look at population-based studies, you look at the cohort-based, even Framingham data, all of them have shown that the stroke risk has consistently gone down. And I think it is unfair. It is unfair to compare historical rates of strokes with the current data from the device and the stroke rates with that. I think it's especially, data from circulation last year was from, I think, over 25,000 patients, which included, and those were not on anticoagulation, and the risks, stroke rate was very, very low. So it has been a consistent theme, and I think we all ought to take a closer look at it.
So, Dr. Karim, it's a tough question, and as you saw in the previous talk by Dr. Miner, there were a lot of indications where the patients could be considered for Watchman devices. Again, you just mentioned that when the patient asks you, what would you do if it is your family? So if it is your family, at what point you would consider Watchman device under whatever the data we have?
Sure. And that's where the clinical judgment that was mentioned earlier, I believe Jared probably mentioned that common sense point and the clinical judgment point. It's very difficult, but what I try to take into account is, number one, if I'm making a decision based on the CHA2DS2-VASc score, I better be taking into account the same type of population that was involved. And I did not get into the details of the CHA2DS2-VASc, but the revalidation data, the numbers you punch into the app and it spits out those numbers, all of those patients, to my knowledge, I believe they were all inpatients who had known atrial fibrillation. They were not the same type of patient you put a loop recorder in for a cryptogenic stroke and come up with a 1 hour of AFib, 2 episodes in a year. Those were not that type of patients. So I think twice before I recommend this procedure in that subset of patients. But somebody who has a fairly high CHA2DS2-VASc score, and I don't know what the definition of fairly high is, but definitely if that sniff test, if you were to say, shows that it's a much higher risk based on those risk factors.
Someone's asking a question. I know she's a electrophysiologist, so I was wondering if you could answer about post-Watchman. If there's no leak confirmed on CTA or TE, do you still do a TE pre-cardioversion? And do you switch from NOACs to aspirin and Plavix? Ed, I'm not
Ed,
sure.
what do you?
Yeah, I can take that. You know, so if the Watchman is has been in, it depends on how long it's been in, right? So if it's been in, if it's been in, you know, say a year, and it's been confirmed to have no thrombus and no leak around it, then you know, patient doesn't need long-term anticoagulation. With electrical cardioversion, I think 30 days is always reasonable. There's some stunning of the ventricle there, and stunning of the atrium that could have some thrombus. And so it's you know, there's no randomized data obviously post Watchman, but I think if you're going to electrically cardiovert someone, it doesn't hurt to do another 30 days of anticoagulation.
Dr. Eifling, are you there?
I am, sir. Can you hear me?
Yes, so we have Dr. Mike Eifling. He's also an electrophysiologist. He's based in Dallas. And Dr. Ed Miner knows him well. Dr. Eifling was in Utah, then he moved to Texas. He's also enrolling in a option trial, which is a randomized controlled trial, post-AFib ablation patients, NOAC versus Watchman. So Dr. Eifling, what are your comments on that?
Well, first of all, I was very impressed with the discussion tonight. And, you know, I think the overreaching opinion I have of this entire discussion is how things have changed and how fast things are moving. So, you know, Dr. Miner went back to 2002. I too was a resident back then. And I remember when that trial came out. And, you know, we don't really think of the AFFIRM trial as impacting a lot of our decisions these days, because in the quote unquote rhythm control group, there was only, you know, 60% of the patients that were in sinus rhythm and 40% in the rate control group were in sinus rhythm. So it wasn't really a fair comparison. And now you fast forward to, you know, PROTECT AF and to PREVAIL. And so I think as data moves forward, our understanding moves forward. We know now that paroxysmal patients have a lower risk of stroke than do persistent patients. That's not what I was taught in medical school. I was taught that everybody had the same stroke risk. So I think that trials like the option trial are very important. Dr. Miner mentioned Dr. Bunch. There's data out of Intermountain Medical Center that show that patients that are post-AFib ablation that are in sinus rhythm have a lower risk of stroke than those that have recurrent AFib. So it's definitely a moving target. I'm excited to see where the field is going. And my prediction is that for patients who have atrial fibrillation, I think that AFib ablation will ultimately end up being shown to lower the stroke risk. And I think that the combination of AF ablation and a Watchman is probably going to be the future.
So Hale, Mike Eifling and I, we knew each other in Texas first before Mike even came to Utah. We were fellows together at Texas Heart Institute. So Mike and I go way back. So great to
So
hear.
I had a very busy practice in New Orleans, practiced 3 years, and Mike Eifling was one of the reasons that I moved to Utah. That I thought that we would form a great group together, but then due to life circumstances, he had to move to Texas. But we still stay in touch.
That's right, exactly, yeah. Sorry about that, buddy. Sorry about that.
Maybe I'll move to Texas, who knows?
Yeah, life's good down here. So
Sure.
Great discussion tonight, guys. It was very, very good.
Thank you.
Yeah,
Thank you.
I liked what you said, Mike, about the chronic AFib. When I feel really good about a Watchman device and feel like I've really helped the patient, it's a chronic AFib patient who's has really significant echo contrast in his appendage or a previous thrombus, and is relatively young, because like you pointed out, Dr. Karim, you know, very elderly patients one guideline I do think needs to change as we become more of a geriatrics associated profession is when do you stop blood thinners and when do you stop everything? And I saw an analysis recently that said patients over 85 should probably not get warfarin. Patients over maybe 92 or 93 should not get Eliquis, kind of illustrating that huge safety advantage of DOACs over warfarin. But I think kind of focusing in on these elderly patients is important. And I like to treat chronic AFib patients who are younger, who have a really ugly appendage. I mean, I think those are the poster child for.
Yeah, that's an important point. If I can add one more thing to it. So again, keep in mind that all these even DOAC comparisons, they were basically non-inferiority comparisons with warfarin, right? So all the warfarin trials, if you look at them, the SPAF, the CAFA, BARAF, the list that I had on my slide, the mean age was 68 years. In fact, one of the trials, I believe it was SPAF, the anticoagulation, because it had an anticoagulation arm and it had an aspirin arm. So the anticoagulation arm, actually, the exclusion criteria was age more than 75 in that patient. So mean age, and I'm sure you all have seen those graphs about US population, and as the population ages, the prevalence of AFib is higher, over 70s and 80s and 90s. So most of the patients we end up seeing were not even included in those original warfarin trials, which we are using as a pivot for comparison for non-inferiority. So when you talk about net clinical benefit, that's where the time to death analysis and that thing comes into play. So I think it's important to take this whole thing in a perspective rather than just triggering to a number by itself.
So we have a few more minutes. Any comments, questions, Dr. Gulati, Jared?
There's somebody asking a question. I know I could answer it, but I'd rather an electrophysiologist to answer it so they get the clear answer. One person wrote, I have a basic question related to ablation. Why do patients need to continue anticoagulation after ablation, since many of my patients ask this question? I was wondering if somebody could say it again, just so everyone gets why.
Yeah, I can comment. I would just say there isn't conclusive data that after an ablation that it's safe to do that. As Mike Eifling referred to, probably lower stroke risk with a successful ablation than with an ablation with recurrences. But it just hasn't been exhaustively studied enough. And I think there's a logical argument for why an ablation might not be helpful, and that you're taking a diseased left atrium and adding more scar, more disease, less contractility to it.
Dr. Karim, you mentioned that patients with paroxysmal AFib or lower burden of AFib, they have lower risk of stroke compared to more permanent or chronic AFib. Those patients have a high risk of bleeding, not an absolute contraindication, but kind of relative contraindication. Would you consider Watchman devices knowing that the risk of stroke is lower in paroxysmal AFib?
Yeah, and again, it depends on their rest of the risk profile, right? So not only the duration of atrial fibrillation, but I'm not sure if the CHA2DS2-VASc of being a female, which gets 1 point, is the same as the CHA2DS2-VASc of uncontrolled diabetes with a A1C of 13. It doesn't give the same. So essentially what we are saying is that a 64-year-old male with a A1C, with a 20-year history of diabetes and A1C of 11 has the same stroke risk as 35-year-old female who has AFib. I mean, it just does not make any sense. And that's why the C statistic was like 0.6. Even in the revalidation study, the C statistic was like, I think 0.66 or 0.67, something on those lines. So we have to take those things in perspective.
Dr. Karim, on that point, I often tell my fellows and otherwise, like, as much as I'm for women, don't give them that extra point unless they have other risk factors, that's how you use the CHADS-VASc score. You just don't give them one because they're a woman and they have nothing else. I don't know. I just wondered if that was your way of using or interpreting that the CHADS-VASc as well.
Yeah, I think, again, I don't have any data to that. I just, in general, if you look at cardiovascular risk standpoint, if postmenopausal versus pre, the risk profile is different. So you're right. That's what I tend to do, that if, let's say, over a certain age, you would start thinking that they may have an additional risk of stroke. I mean, we try to make things binary, but in the real world, they are not binary.
Yeah. Dr. Galati, that's correct. It's a 34-year-old woman that's a CHADS-VASc of 0. So it's until they accumulate another point. So it's hard to have, as a woman, to have a CHADS-VASc of 1. So if I could make one comment, I would like to congratulate my colleague Ed Miner, half jokingly, on an extremely restrained Watchman endorsement from an interventional cardiologist. That has not been my prior experience with interventionalists and Watchmen, and so I thought it was an excellent talk.
Yeah, and then I didn't try to gang up 3 EPs on 1 interventional cardiologist. So, I was trying to bring Dr. Gulati as well to kind of have that, moderate effect. So on this, it's 9 o'clock, and we are going to end this session. Again, this session will be posted on YouTube on our channel. Our next webinar will be in few weeks, and our focus will be on new heart failure therapy, heart failure device therapy. So stay tuned. Follow us on our Twitter. That's where we try to advertise our next webinars. And please give us feedback for this session, and you can claim CMEs. If you have any questions, please email me or Viet or Dr. Gulati. Thank you so much, and good evening, good night.
Thank you.
Thanks.
Thank you, everyone.
Thanks, everybody.